Okay, we are going to start with acute complications of diabetes, and then we will go into the chronic complications. So we'll talk about hypoglycemia, hyperglycemia, DKA, and HHS. So hypoglycemia, a blood glucose less than 70, that's important to know. You may see some other information that it's a different number, but for the purposes of 104, I really want you to know less than 70 is hypoglycemia. That really is the latest information. Anything less than 70 is really critical because hypoglycemia can quickly worsen and it can become life-threatening. It can result in coma, death, so it really is an emergency. With hypoglycemia, you do have your neuroendocrine hormones released to help, some of those counter-regulatory hormones to help increase and correct that low blood sugar. Your autonomic nervous system is activated, that whole epinephrine. So some of the symptoms that a client experiences with hypoglycemia is really due to the activation of that sympathetic nervous system. So I want you to take a minute and just kind of visualize a patient that's diabetic, that maybe had insulin timed appropriately. 15 minutes before breakfast, they had their dose of aspar insulin, and then all of a sudden their breakfast tray arrived and they just had lack of appetite and just decided that they couldn't eat anything. Dietary came in, took their tray away before you could get back in the room, and you didn't realize that they didn't eat their breakfast. About 30 or so minutes later, the patient starts to have pallor, shakiness. They're very sweaty, hungry, nervous. Those would be early signs of hypoglycemia. If the patient didn't ring their call light or nobody noticed that the patient was having these symptoms, it could worsen and the client could start having slurred speech, become disoriented, perhaps lethargic, and it could progress to coma. Some of these symptoms actually mimic alcohol intoxication, and there's been a lot of training with law enforcement to really be aware of that somebody might present as though they're intoxicated, but it might be somebody that's diabetic and actually having a pretty significant episode of hypoglycemia, and they actually could identify this and save somebody's life. So it is very serious. It can result in seizure activity. So I mentioned hypoglycemic unawareness when I was talking about my client that received the pancreas and kidney transplant. Hypoglycemic unawareness is a client that really has no warning signs. They don't become symptomatic, and that's really dangerous. So these clients may have a slightly higher target blood glucose control, or a slightly higher target blood glucose because of their risk of becoming hypoglycemic. A lot of times this can occur when a client has had persistent episodes of hyperglycemia for a long period of time, and it's kind of damaged the nerves and the in the brain, the spinal cord, the sweat glands, the GI tract, so the client just doesn't feel those symptoms. There's even pediatric clients that do have hypoglycemic unawareness, and they may have loud alarms if their blood glucose drops so that their parent can wake up if it's during the middle of the night. If older patients have repeated episodes of hypoglycemia. They can develop hypoglycemic unawareness. A client on beta blocker could be a cause of the hypoglycemic unawareness. So causes of hypoglycemia, extremely important to understand. Perhaps the patient didn't eat. Maybe they had too much insulin. Maybe they exercised without having a snack or a meal before. Perhaps a client had ingested significant amount of alcohol. And again, alcohol can cause hypoglycemia. And there's other reasons here. Those are the most common. The earlier you can identify the hypoglycemia, the better the outcome. It is easily treated if it's identified early. So any blood sugar that's less than 70, you would want to treat. If you don't have a glucometer available, or let's say you're doing home care and you don't know how to work your client's glucometer, but they're a known diabetic and they're symptomatic, you're going to act on that. So treatment of hypoglycemia, the rule of 15s, very easy. If your client is alert and oriented and able to safely swallow, you're going to do the rule of 15s. And that is 15 grams of a rapid acting glucose. You're going to recheck the client in 15 minutes. If they're still less than 70, you're going to repeat that. So it's important to know what is 15 grams of a fast-acting carbohydrate. That would be 4 to 6 ounces of juice or soda. So apple juice, for example, regular Pepsi, 2 tablespoons of raisins, a tablespoon of honey or sugar, 8 ounces of non-fat milk, 5 to 6 lifesavers, glucose tablets or gel that you can purchase over the counter. So it's important to, and that would be only one of those, would be 15 grams of a fast-acting carb. It's important not to overtreat, and it's important to know what would be a fast-acting carb. So again, you're going to recheck your client's blood sugar in 15 minutes. It's important to wait that 15 minutes. You need to have time for that oral glucose to get into the body. And you want to avoid overtreatment because you don't want to be dealing with like a hyperglycemic. You do want to avoid fat because it will slow the absorption of glucose. If your client is not alert, NPO, unable to swallow safely, you would then, in acute care, administer 50% dextrose IV. Each facility would have their own hypoglycemic protocol, so that would be important to familiarize yourself with when you first start working as an RN on a unit. You want to be able to review that prior to actually needing to treat somebody for hypoglycemia. If the client did not have IV access, or if you were working in home care, then IM glucagon would be the treatment. So I want to just move on to the next slide, and I'll talk about administering glucagon and dextrose. So first on the right here, this is 50% dextrose, 25 grams in 50 mLs. So it's a pretty high percentage of glucose. This is exactly how it would look if you pulled it out of the Omnicell in clinical. You do connect the medication with the actual syringe. It just kind of, you would screw it on, and then the cap comes off the end, and it would fit right on your IV port or tubing, and you would administer it. So it's an extremely large syringe. You definitely would want to wear gloves because it is very sticky. It's a slow IV push over 3 to 5 minutes. Honestly, it's really difficult to administer because of the type of how viscous the solution is. So you really couldn't administer any faster than that if you wanted to, but it is a 3 to 5 minute push. It's a vesicant, so you really want to do a thorough IV assessment, a good flush with 10 mLs after. And how long do you think it would take for the client to respond if you administered 50% dextrose? They would respond pretty quick. So you could even recheck their blood sugar in 5 minutes or so because they are going to respond much quicker. You could wait the 15 minutes, just kind of memorizing the rule of 15, but you could check even sooner. If your client did not have IV access, on the left here, this is a glucagon kit. A client would have this emergency glucagon kit. So any diabetic that's on insulin therapy, they would have to be taught how to reconstitute the powder and draw up the solution, and it is an IM injection. So, and you would really need to teach family members, a neighbor, a friend, because a lot of times if a client is to the point where they need IM glucagon, they're really a lot of times unable to self-administer that. It can cause pretty rapid nausea and vomiting, so you would want to position the client on their side and then recheck their blood glucose in 15 minutes. If the client was still not over 70, you would want to be calling for help if you were in home care, but you could repeat either of the oral or the IM. You could repeat it twice. This will not be on your exam, but this is an inhaled glucagon. This just came out within the past year. It's pretty expensive, but it does not require an injection. It's a nasal spray glucagon. So I want to recap treating hypoglycemia because there's a couple important steps that I want to just state. And so you always want to identify based on those symptoms, checking the blood glucose, treat as soon as possible, whether it's the oral rule of 15s, the IM glucagon, the 50% dextrose. So you're treating the client until they're greater than 70, and then you want to pause and you want to kind of like think back, what happened? What caused this episode of hypoglycemia? Again, did they not eat? Did they have alcohol consumption? Did they take too much insulin? What caused the hypoglycemia? Because you want to prevent that from happening again. So identifying that is super important. And then you want to look ahead. Is the client going to have a meal within an hour? If not, then you need to provide a complex carb because all of these treatments are short term and the patient is going to crash again, and you'll be repeating this whole process if you don't think ahead and either give them a complex carb or a meal within 1 hour. So those are just some things to think about. If you had a client that was NPO, perhaps waiting for surgery, then you might be notifying the provider, telling them this whole situation, what the blood glucose was, how you treated it, how they're out now, that they're still NPO, and maybe asking for an order with IV fluids with dextrose. So it really depends on your patient, the setting, the situation. Hypoglycemia will be on the exam, it will be on the final, you will see it in practice. You may just see it out shopping at a grocery store, because that happened to a student last semester. We went over hypoglycemia. She went to Hannaford, and there was a customer there that was hypoglycemic, and she was involved in helping that shopper. So hyperglycemia, elevated blood glucose. I won't read through all of these symptoms, but probably the most classic would be that polydipsia, polyuria, polyphagia initially, and then the client may have no appetite, abdominal pain, nausea, vomiting, abdominal cramps. If it's not acted on quickly, that's when it's going to progress to one of these acute complications, DKA or HHS, which can be life-threatening. So some causes of hyperglycemia: an illness, like I mentioned, the example with the GI bug. One of the most important things to teach our diabetics when they're sick and they're a type 1, they need to take their insulin, because anytime somebody is sick or ill, it's a stressor on the body. They're going to have increased cortisol. They're going to be at risk for hyperglycemia. And even if you're vomiting and nauseous and unable to eat, you are going to be hyperglycemic. So you really need to take your insulin, check your blood sugar very frequently, every hour, every 2 hours, drink fluid, check your urine for ketones. That's super important anytime you're sick, because that's a big cause of hyperglycemia and then progressing to one of these more acute complications. So any sort of infection, corticosteroids, because of, again, replacing that glucocorticoid, ingesting too much food, not taking enough medications, inactivity, all of those are examples of hyperglycemia. So I covered this information on the last slide when I was talking about what to do on sick days for your diabetic, but definitely that communication with your physician's office. But again, I'll just repeat it because it's so important. In big letters, write in your notes, take your insulin, check your blood sugar every hour, every 2 hours, dipstick your urine for ketones, drink water, and just be in constant communication. So the last two acute complications, diabetic ketoacidosis and HHS. We'll start with DKA. So basically, what's happening with DKA is there is a deficiency of insulin. So it's definitely more common in your type 1, but it can occur in your type 2. And these patients are extremely hyperglycemic. They don't have the insulin, that key to help glucose enter the cell for energy. So ketosis does occur, acidosis, the profound dehydration, because glucose has an osmotic effect, and patients are having that polyuria, and that is actually the number one issue. If you want to highlight that, star that, with DKA, the number one life-threatening issue is this profound dehydration. So some possible causes of DKA would be illness. So like my student a year ago, that type 1 on an insulin pump, gastroenteritis, insulin pump wasn't working properly. She ended up in an early DKA. Infection, not having enough insulin, or a client that presents to the ECC because they've been having this polyuria, polydipsia, and now they're presenting in a DKA state and they're an undiagnosed type 1 diabetic. You will see that often. It could be a client that unfortunately is trying to harm themselves by withholding insulin, and they may end up in a DKA situation. I've unfortunately cared for quite a few patients that intentionally severely depressed, suicidal, and withheld his insulin, and he was a type 1 diabetic and ended up in critical care in DKA. So I'm going to let you read through this slide and the next slide, and then I'll go over what's going on with the pathophysiology with DKA on the figure from your textbook. Okay, so with diabetic ketoacidosis, the circulating supply of insulin is insufficient. So glucose cannot be properly used for energy. This causes the body to break down fat stores as a source of fuel. So ketones, ketoacidosis occurs. The cells are starving for sources of energy, sending emergency signals to the liver, and the liver releases more stored glucose, which contributes to the already hyperglycemia. So now it worsens the hyperglycemia. The client is having ketoacidosis. The patient is experiencing polyphagia, polyuria. The polyuria is causing profound dehydration and also electrolyte imbalances. Patients are at risk for severe dehydration. They can actually become, that's the most life-threatening complication, is the dehydration and adequate perfusion to vital organs. So you are going to see the poor skin turgor, the dry mucous membranes, tachycardia, hypotension. These clients may be lethargic, weak. You may see abdominal pain, anorexia, nausea, and vomiting related to the acidosis, the metabolic acidosis. Kuzumal respirations, those rapid, deep respirations where the client is trying to blow off CO2. That fruity breath, if you want to star that, that's characteristic of DKA, that sweet, fruity acetone breath. Clients usually present, if you work in acute care, you're going to see high blood glucose, so 600, 700, 900, crazy high, but anything greater than 250, you'd see them, acidotic on their blood work, ketones in their urine. So this may be treated as an outpatient if it's detected early and the patient's hydrating and checking their blood sugar and increasing their insulin and constant communication with the healthcare provider. When it reaches the point where it's an emergency state and the client is admitted to critical care, a lot of times it's an undiagnosed diabetic or it was not detected early. So of course airway would be number one, so supplemental oxygen, large bore IV, and aggressive fluid resuscitation is number one. So highlight that, star that. Even if your client's blood sugar is 900, fluid is going to be the number one, because remember, these clients are profoundly dehydrated, they're hypovolemic, and you're concerned about adequate perfusion to vital organs. So after airway, it's fluid, fluid, fluid. Then you're concerned about electrolytes, you're concerned about hyperglycemia. You do want to know what your client's potassium level is before you start insulin therapy, because once you administer IV insulin, that's going to cause a shift of the potassium into the cell. So if your client is already hypokalemic, that could cause a life-threatening situation. So you'd be looking at blood glucose, potassium level. If their potassium level was okay, you're going to go ahead and administer IV push regular insulin, and then start an IV regular insulin drip most likely. And then you're going to be checking that potassium level perhaps every 2 hours. They would be on cardiac monitor, because that's something that you can use to assess for changes in the cardiac rhythm with fluctuations in potassium, because shifts can occur after you start the insulin therapy. You don't want to bring that blood glucose down too rapidly, so it's going to be over the next 48 hours that you're correcting that blood glucose, monitoring electrolytes, providing hydration, cardiac monitor. That's an overview of the treatment. Once the client's blood glucose gets around to 250, you're actually going to change the IV fluids and add some dextrose, because you'll be weaning the client off the insulin drip and switching them over to subcutaneous insulin and frequent blood sugar checks. And again, you don't want them to become hypoglycemic. Hyperosmolar hyperglycemic syndrome, HHS, is the last acute complication that we're going to cover. This really occurs in your type 2 diabetic. It actually has a higher mortality rate than DKA. It is a critical, life-threatening situation. And the reason that it has a higher mortality rate is this occurs in our older adult that's type 2, and a lot of times before the problem is discovered, usually the client is quite hyperglycemic. They have other comorbidities, and it's usually caused by an underlying infection or illness, and so they have a lot more going on all at once. It is similar to DKA because these clients don't have enough insulin, but they actually, because it's in a type 2, they do have some insulin, and that's why it's a much more critical state by the time it's discovered, and that contributes to the higher mortality rate. So again, these clients have hyperglycemia. They're also having this large amount of urine fluid loss, the polyuria with this osmotic diuresis, hypovolemia, electrolyte imbalances, and they, again, are having a lot of the symptoms that the client with DKA are experiencing, except they are not acidotic. There's usually an underlying infection, UTI, pneumonia, sepsis. It could be an older adult that was never diabetic, and it was an undiagnosed type 2 diabetes in the presence of an onset of an infection. So like I mentioned, the type 2 does have some circulating insulin, so a lot of times the blood sugar is much higher by the time it's diagnosed, and there's some neurologic manifestations. Could be seizures. Ketones are usually absent, but they can be minimal. They actually changed the name of this disorder. It used to be called hyperosmolar hyperglycemic non-ketotic syndrome, and because there can be minimal ketones, they changed the name now to just straight HHS. The treatment for HHS is really very similar to DKA, so you really don't have to memorize anything new. You're still concerned about airway. Hydration is number one, so normal saline infusions. Same idea, when the blood glucose gets around 250, you're going to switch them over to a solution with dextrose. Electrolyte imbalances. So you're going to be looking at that potassium, you're going to be administering insulin, and then also treating that underlying infection. So you're really going to be closely looking at neurologic status, renal status, cardiopulmonary status as a nurse, and closely monitoring your client with DKA and HHS. So the last part of this diabetes PowerPoint is the long-term complications of diabetes. So you can see long-term complications impact the entire body. And this is really due to persistent hyperglycemia. So if we can diagnose early, do really awesome patient teaching as an RN on diet, exercise, medication, weight loss, we can really have a huge impact on preventing these long-term complications. We'll talk about microvascular complications, so your nephropathy, your retinopathy, the dermopathy. We'll talk about macrovascular complications involving those large vessels, so that would be peripheral vascular disease, stroke, atherosclerosis, coronary artery disease. There's also neuropathy, so autonomic neuropathy, so gastroparesis would be one example, neurogenic bladder, peripheral neuropathy. So it really affects a lot of the blood vessels, the nerve transmission. It can have just a really big impact on the overall body, and to prevent these, having really good blood glucose control. So we'll start with angiopathy, damage to the blood vessels secondary to that chronic hyperglycemia. The leading cause, I mentioned on slide 1 that cardiovascular disease was the leading cause of death in diabetics, 68%, and then 16% responsible for strokes in our clients 65 and older. So that's really huge diabetes-related death statistics. So we'll talk about the macro and micro. So patient teaching is super important. We're concerned about retinopathy, so we really want our diabetic clients age 40 and older to have an annual eye exam. If they're younger than age 40 and diagnosed with type 1, within 5 years, we want them to have an eye exam. And if they're younger than age 40 and diagnosed with diabetes, at the time that they're diagnosed with type 2, we want them to have an eye exam, and then annually. They really should be, and that's to assess for evidence of retinopathy. Nephropathy, annually, they should have their urine checked for protein. They should be having BUN, creatinine, GFR assessed, screened for neuropathy with foot exam, monofilament testing, where they assess for sensation on the bottom of the foot. They want to be looking at blood pressure, cholesterol. This is all annually. So if you want to star that in your notes, that's an important patient teaching point. A daily foot exam by a patient is super important. So they should be looking at the bottom of their feet daily, using a mirror if they're unable to see the bottom of their feet, making sure there's nothing in their shoe because they may have decreased sensation. I had a patient that was a young construction worker, and he was a type 1 diabetic, and he had neuropathy, and he worked all day long in steel-toed work boots with a Lego in his boot, and he developed a foot ulcer. So that's an important, foot inspection is important. So macrovascular, again, those large vessels. We're going to talk about peripheral vascular disease as a separate topic, but it really is a major chronic complication of diabetes. I do want you to know be able to name microvascular versus macrovascular. And just remember, atherosclerosis is that buildup of plaque within the large vessels, and that causes cardiovascular MI, can cause an MI, can cause peripheral vascular disease or stroke. You want to minimize any other risk factors, so smoking is a big one. If you're diabetic, you're already at risk for all these complications, and then if you smoke and you're diabetic, that increases your risk. So smoking cessation is really important. Obesity, again, we talked about hypertension, high cholesterol, the importance of good nutrition, activity, weight loss. There's two different types of retinopathy. It can lead to irreversible long-term loss of vision. So the main goal of prevention would be good blood glucose control and good blood pressure control. Once the client is diagnosed with diabetic retinopathy, preventing any worsening, there are some procedures on the next couple slides that can be done, and just good blood glucose, good blood pressure, and regular follow-up would be good, important patient teaching points. So diabetic nephropathy is a leading cause of end-stage renal disease, and clients on dialysis or requiring kidney transplants. Patients that are hypertensive, and half of our diabetics have diabetes and hypertension, so there's really a high risk to the kidneys. And then if you have other risk factors, smoking, family history, you're at an even higher risk. So annual screening, if you want to just jot this down off to the side and star it, one of the first indicators of kidney disease, and this is really important, is the presence of protein in the urine. So that would be something that they would be screening for annually, and that would often be the very first sign that there's some nephropathy. Again, they would be monitoring renal function. And if a client is diabetic and hypertensive, a lot of times they will place the client on an ACE inhibitor or an ARB, an angiotensin II receptor antagonist, to help slow the progression of the nephropathy and then really aggressively control blood pressure and blood glucose. So neuropathy, super important chronic complication of our diabetics. It affects 60 to 70% of patients with diabetes, so that's a very high percentage. A lot of times it's affecting the hands, the feet, with decreased sensation. It's not just decreased sensation, it can also be very painful. Patients complain of burning, tingling. Some patients can't even tolerate a sheet or blankets on them, and it can really impact quality of life. Clients should be screened for this annually. For a type 2, it would start at the time of diagnosis, because remember, our type 2s could be 5-6 years, have diabetes, and have no awareness. So they could actually have some of these long-term complications at the time of diagnosis, which is scary. And then type 1 would be 5 years after diagnosis, and then annually. And that's the same with a lot of these screenings that we've been talking about. So with sensory neuropathy, the most important assessment for the nurse is just to thoroughly inspect skin. That's important for neuropathy, because again, the client is going to have altered sensation, and that's the most important piece. You do want to assess how their blood glucose has been managed, and good blood glucose control is going to prevent worsening neuropathy. There are drug therapy for pain that's associated with neuropathy. So topical creams like capsaicin can be helpful. Some of your antidepressants, so the tricyclic antidepressants, the SSRIs, the mechanism of action of how it actually helps with the pain is unknown, but it is effective in treating pain associated with neuropathy. Anti-seizure medication, so I know you covered gabapentin with Justin. That is the most common drug therapy for neuropathy. Pregabalin, or the brand name is Lyrica, you may have been administering that in clinical. Duloxetine, which is one of our antidepressants, the brand name is Cymbalta. A lot of times we'll be giving meds in clinical, and I'll ask, what all the meds are for, and then we're at the bedside, and the student nurse is like, and this is for depression, and the client's like, oh, I don't have depression, but I take that for my neuropathy pain. So just, again, a lot of the drugs have different uses, so you may see that. So autonomic neuropathy, again, that's our hypoglycemic unawareness. Clients can have problems with bowel incontinence, a neurogenic bladder, where they're unable to fully empty their bladder and they're lacking that sensation. It can impact sexual function. Patients can have chronic nausea and vomiting from a slowing of their GI tract and this gastroparesis, where they're unable to really consume foods or fluids, and they become dehydrated and they have to be admitted to the hospital for IV fluids, antiemetics. So that can be really problematic for patients that have gastroparesis related to autonomic neuropathy. And then also clients can be sitting in the chair at rest watching TV, have no pain at all, and have a full-blown MI that have autonomic neuropathy. So it really can impact sensation, and it impacts the entire body. So this is probably one of the more common complications with diabetes when we talk about peripheral vascular disease and wounds, but a diabetic that has peripheral vascular disease and develops a minor wound, so maybe just in between the toes or the tip of the toe, that could really take months, 3 to 6 months. Some minor little nick in the skin could take a really long time to heal just due to that delayed healing. This is an example of a necrotic second toe prior to amputation and then after amputation. So I'm sure many of you have cared for a client that maybe had a toe amputation in clinical. So there's a lot of wound care involved, glucose management, but also body image, and grieving the loss of a body part can really be huge for clients. I know I had one patient, and the first time you took this dressing off after surgery, he didn't want his wife to be in the room because he didn't want her to see how his foot looked. And you could tell he was visibly upset looking at his foot for the first time. Patients also have problems with mobility. You wouldn't think a toe would have that much of a role in balance, but it really does. So they're at risk for fall and injury. So just some nursing things to think about. So patients with sensory neuropathy, they may walk around with something in the bottom of their foot and have no awareness and end up with this whopping infection and wound. So just inspecting skin and foot inspection is so important. I had a client that in the summer he was out repairing his deck and he stepped on a decking screw. I'm sure there's a more technical term for that. But he walked around with this screw in the bottom of his foot for a week and didn't know about it. He ended up losing his foot. So good patient education can help prevent those complications. We're going to talk about peripheral arterial disease after this section, and that plays a major role in wound healing, and we'll talk about treatment for that. So diabetic clients really should not walk around barefoot. They should have proper fitting shoes. Sometimes they need special diabetic shoes that are made for them. They really should have a regular care by a podiatrist. Again, a minor injury could lead to months of healing and increased risk for infection. They should be inspecting their feet daily. You really want to avoid the use of heating pads. Use caution with pedicures, anything that's going to increase the risk of infection. Minor first aid, a lot of clients don't know to wash and dry the area and apply an antibiotic ointment and cover it. So that can really prevent a lot of complications. So this would be important, good patient teaching. Charcot's foot is a joint malformation where the client puts uneven weight on a part of their foot and it places them at risk for ulcer formation. So perhaps maybe some of you have seen that. So the last complication here is dermopathy, and it's really affecting those tiny little capillaries underneath the skin. So you can see a variety of different pictures of different skin lesions. So they could be dry red oval patches on a client's lower extremities. So this is one example. And again, I'll just let you look at these pictures, but this is another skin complication. And this is the last skin complication that I have here on the slides. But you know, often I've heard dermatologists say, you know, a lot of clients make an appointment to see a dermatologist for some of these skin symptoms, and they actually have an underlying medical condition. So this would be one example, a sign of possible insulin resistance. So patients that are diabetic are at an increased risk for infection. I'm sure that you've heard a lot in the news about clients that are diabetic and increased risk for coronavirus. But early treatment of any sort of infection is important, and the minor first aid, like I mentioned. Diabetes is a lifelong condition. It's a progressive condition, so there are high rates of depression, anxiety. There's a cost burden. There's a lot that we talked about with diabetes, and it can definitely have some psychologic considerations for your clients. There are some, when you take psychiatric nursing in the last semester of nursing, Kristen will talk about eating disorders in adolescent, more so in adolescent clients, where a type 1 diabetic might decrease their dose of insulin or withhold their insulin to promote weight loss. And that's a big concern, an eating disorder involving a type 1 diabetic, and they could run into big trouble with DKA and really end up in a life-threatening situation. So identifying signs of that and good patient education. And the last slide here is some considerations for our aging diabetics. So a lot of times they have multiple comorbidities. Their target blood glucose might be at a higher slightly higher level because they are at a higher risk for hypoglycemia. They may be on multiple medications that impact blood glucose control. They may not be able to manage their own diabetes. So you have to really individualize the patient teaching, get the assistive devices so that they can provide as much self-care as possible. So talking glucometers, magnifying glasses for drawing up insulin, any sort of measures to help assist this population with self-care is important.